Ashish, may I ask you something while people are coming in? Are you going to allow them to ask direct questions to me, or are you going to ask them to ask the questions in Q&A or chat so that we can discuss them at the end?
So yeah, so during the discussion, we will have it in the chat. But after that, we will open the platform, and if anybody wants to ask questions, with the larger crowd, it gets sometimes little difficult to pinpoint and ask him to unmute it.
Okay.
We would prefer chat, but if required, we don't mind opening it.
Okay, because I won't be able to see the chat on the Zoom very easily.
I'll take care of that.
So if there are any burning questions, you can stop me, and I'll be just like perfect.
Yeah. I think Dr. Grover is going to take care of that.
Okay, fine.
Surely.
Thank you, Dr. Grover.
Definitely, sir.
Yes, sir. Grover, sir, good to go.
Okay. Good evening, all. On behalf of ISP, I welcome you all to the evening session of the GISP and GIAP Joint Symposium. We have had a wonderful session in the morning, and we are good to go for the evening session. So before we start this session, let me give you an overview of the topic we are going to have today. And we have two wonderful speakers who would put their insights into this topic. Education, especially in the medical field, is a highly dynamic ecosystem incorporating complex academic scientific inputs, since it entails teaching of new skill sets and novel clinical experiences, which one comes across throughout the everyday life routine of a health professional. Within this academic learning, there are twin processes. The first one is based on a straight-jacketed, well-structured instructional mode by the teacher for the student to acquire knowledge about the fundamental principles which will be of help during daily practice as a general practitioner. The second process channelizes bringing this acquired knowledge to practice based on research. And this is what we are going to focus today as to how MDS and research can go hand in hand. We have with us Dr. Ashish Jain, a very renowned speaker. Sir is professor and head at Punjab University Dental College and also director IQAC of the same university. Sir has been the past dean of the Punjab University Dental College, and of course, sir has been an ex-president of ISP also. He has the distinguished meant of being a rare researcher who has an array of research funded projects from many central agencies. Ladies and gentlemen, we have Professor Jain before you, Professor Jain now before you to present his insights into today's topic. Welcome, sir.
Thank you, Dr. Grover. Let me just first share, and then we will talk on that. So you want me to, I think I need to open that up. Praveen, you need to just guide me because I'm not on my computer.
Yes, sir. Just keep your PPT open, sir. Then you can see that share screen. You're on system or Mac, sir?
I'm on system.
System, Windows, right? So just click on that share screen button.
Let me first figure out where my presentation is.
Okay.
Ahead. All right, so this goes here. To the share screen.
share screen and select your PPT in that pop-up.
Still not showing the PPT actually.
No, click on share screen and under basic you can see.
I've done that. Here it is.
Yeah. Yes, sir. Go
So
to
it works.
full screen. Yeah, it is visible.
Yeah.
Go to full screen,
Yeah.
sir.
Okay. Thank you, Prabhu.
Yes, sir.
Thank you, Dr. Grover, for the words that I don't deserve, certainly. But thank you so much for at least making me feel good about it. And welcome all the students, our lovely students. We see you in good number, and as we move on, I'm sure we'll have more of you joining us. So before we move on, I really need to share something with you. So the other side of the screen that you see, the gentleman with equal gray hair as mine, Al Kantarchi. He's a name to reckon with. I mean, all of you have heard about him, all of you have read about him, all of you would want to actually, see him in person and touch the flesh and do that. But I have been really fortunate to have started my career under his guidance, so as to say. I mean, I'll take 2-3 minutes, but I can't really stop myself from saying this. So after having finished my post graduation from NIR, I was fortunate enough to get a postdoc fellowship with Dr. Van Dyke at Boston University. That was the year 1999. So that was my first flight ever in my life, and that first flight was destined to go to Boston. So you can't get luckier than that. And the moment I landed in Boston, there were these two gentlemen standing there at the airport with Dr. Van Dyke and the other person whom you see on the other side, a lot younger at that time, but equally handsome. So he was there, and that was my first interaction with him. He was actually working with Dr. Van Dyke a year and a half prior to my joining there. So he was sort of, senior to me there. And from day one till the time I left Boston 3.5 years later, not even a single day I can say, passed without us interacting with each other. And there have been, those are stories for another day. But I owe a lot to whatever we could do in Boston. It was essentially, because you were there to guide us, and we had a wonderful time, and that friendship still continues. There have not been a single occasion when I have requested Alp and PJ, his wife, to be with us, and they have said no. They have traveled all the way to India on occasion more than once on a simple invitation. They have agreed to stay whichever way we have wanted them to stay, never complaining ever. But Alp, really can't thank you enough for all what you have done. Thank you very much, Alp. And okay, so students, so the topic that we are going to touch upon today, and Alp is going to speak more than what I would. I would just lay a little groundwork for that, so that all of us are on the same page. Yeah, the idea of this presentation today and talking to you, and please be interactive. Please talk to us. Give us your feedback. You ask as many questions as you want. Dr. Kentarthi loves questions. If you don't ask questions, he really gets annoyed. So you please ask questions. Otherwise, I'll have to make up questions for you. So do that, please. And the idea is how do you see your MDS? Do we get into our postgraduate training only to learn few clinical procedures and get out of our MDS and then practice those procedures all our life? Is that our whole agenda of spending 3 most valuable years of our life to run few selective procedures, for which, honestly speaking, 3 years probably is little overkill. If you have to really delineate the procedures, if you are there only for the procedure, you can probably learn those procedures in 6 months of time and then go out and practice. Or is it something else that MDS is supposed to be? The master's program is supposed to be. You are going to be a master in a specialty. And when you are a master in a specialty, there cannot be a super master. So that essentially means that you have to master the art of the science, the art and the science of the subject that you have been trained in. And that art and science cannot be restricted only to clinical. Clinical is important, no doubt about it. But it what is it that you are actually giving back to the profession, to your specialty in terms of the research? Have you done anything in your 3 years which would give some value addition to the specialty? Have you done something in those 3 years which 20 years down the line you will be proud and still say that that is what I did? Look at that paper that I published at that time. Because we understand moving out of your MDS, very few would stick to research, partly because we are not research bent mind anyhow. Most of us would want to either get into clinics, if not into clinics, want to get married and settle. So essentially meaning these are the only 3 years. These are the only 3 years for you to do something worthwhile. These are the only 3 years and only 3 years in your life when you will be able, when you have the liberty of spending 100% of your time into something that you should be doing. There is no other distraction. There is absolutely nothing which stops you from spending your 6 a.m. to 6 p.m. or beyond that into a lab doing some research. So this is what we are going to talk about today. There are a lot of excuses we will come to that we can't do this, we can't do that, and we'll touch upon that also as we move along. But let's start with our presentation. So MDS and research, can they go hand in hand? And when I say research, I mean research. I certainly do not mean a, a study for the heck of a study. When you say research, then that means that there is a viable question attached to the research, a question which the literature also needs an answer, not a question to which there is already an existing answer. And that is where we all falter in terms of spending our 3 years. Most of us, and including us also when we were young, spend our 3 years in doing something which is not addressing any pertinent gap in the a pertinent gap in the science of periodicology. So just to lay the base to the story. So in 1947, of course there was no MDS institution, and 1959 was the first time when postgraduate departments were established for periodontology at Government Dental College in Hospital Bombay and Nair Hospital Dental College Bombay. I'm proud alumni of Nair Hospital Dental College for my perio speciality. That started in 59, and almost 70 years down the line, today we have 269 dental colleges, and we have 800 MDS postgraduates passing out each year. And these are the numbers for only the specialty of perio. So we have 800 periodontists passing out every year. Why is it that we are not able to do good research? Why is it that research is not there in our mind when we are joining post-graduation or even after having joined post-graduation? I think the problem lies in these 2 or 3 slides. This is a guiding document from Dental Council, which tells the dental institutions that what is it that you are supposed to be teaching to your students? What is it that the student should be knowing in terms of skill sets for them to successfully complete the course of masters in dental surgery in the specialty of periodontics. And if you go through them from module 1, which starts at first year, it talks of preclinical work, it talks of some basic diagnostic microbiology, immunology, introduction to genetics, and talks of clinical work. The module 2 talks of clinical. Module 3 talks of all the clinical procedures. Module 4 again talks of clinical work. Module 5, second year, talks of clinical work and surgery. Module 6, another set of clinical work. Module 7, more clinical. Module 8, publication of an article in a scientific journal. Now, which article? Did you mandate the student to spend a specific time of their post-graduation into a scientific research. Yes, we did, because the student is supposed to do the dissertation. And unfortunately, so how the dissertation topic is decided? The synopsis of the dissertation topic is to be given within the first 6 months of the student joining the specialty. So somebody who has just taken the first step in periodontology, you are asking him to write a topic on which he intends to spend the next 3 years of his life, without really going into the topic per se, into the specialty per se. And that's where the dichotomy starts. And that's where we hunt for topics, which are not really scientific in nature. So it is not that DCI says you don't do research. The problem is we and when we say we as academicians have actually taken the wordings from the Dental Council of India's Holy Sermon as our Bible, and we want to stick to it as if deviating from it would be a sin. But then that is not a true justice to your 3 years. If all you are learning through these 9 modules is clinical and more clinical and more clinical and more clinical, you learn that, that's okay. But then there are no laterals to it. Okay, dentistry certainly has transitioned from a purely clinical science to an extended scientific discipline, contributing significantly to global research over years. For a statement, I'm making this contradictory statement to what I am saying to have my points cut across to you, that we are contributing significantly, and you would know that once we look at the numbers. And we did this analysis at our end, due to be published anytime now. Wherein we have looked at the scientific output of our dental community all through these years on various parameters, of course, and some of the results I'm sharing with you. So for the time period from 1955 to 2007, US ranked first with maximum publications. Right now, I'm being very quantitative. I'm talking only of numbers. Ranked first with maximum publications ranging in around 79,000 from 55 to 2007. That is a good 52, 53 years. And during the same period, the publication from India was only 2,138. However, things drastically changed post 2007. In the time graph of 2008 to 2021, US still have the maximum publications, which is 46,000 now, in a gap of say around 13 years. But look at India. Indian publications are now 16,960 in 13 years, vis-a-vis 2,000 publications in 55 years. From 19th rank, we have shot to 3rd rank world over in terms of quantity of publications. But when we do a qualitative analysis, things fall flat on our face. Whatever we were publishing earlier probably had good quality. What we are publishing now has gone down drastically. Some of this could probably be the reason that the number of publications, because this is rubbed against the number of publications, so of course the citations are bound to go down. But in terms of quality, we have not really improved too much. Not improved, rather. We have actually drastically lost ground in terms of average citations per paper. If we look at overall distribution of dental publication in Scopus, we have published around 15,000 total till now. From 2007, it is 1479 till 2007, and after 2007 is 13,707. It's only the articles, and of course the same is, the books have stayed the same, the book chapters have stayed the same, the conference papers have come down, but right now what we are interested in the number of articles. This looks amazing if we are talking of number of publications. Look at the graph. I mean, it's almost like not a good corollary to make, but this is almost like a COVID graph. It shoots. What is the reason for this increase in number? To my mind, the reason for this increase in number is only because of one direction from Dental Council of India, which probably came in 2007 or 6, wherein the dental faculty was forced, and apologize for using this word, but dental faculty was forced to have certain number of publications if they want to get promoted. And that pushed the things left, right, and center, and that is where the spike in the graph came. So all of a sudden we were publishing. We were publishing, but just publishing. We were not looking at the quality of the book. And that is why we do not have citations. We do not have our publications in the best journals across the world. We are still so much dependent on our homegrown journals. We are still so much dependent on hunting for a journal which would publish easily. We are still so much dependent on staying away from the journals from where the rejection rates are. But anyhow, but the positive picture is these are the overall description of the top 5 dental journals on the basis of number of articles published from 1955 till date, and these are the 5 journals, and proudly our journal also figures in that, and figure quite high in terms of the number of articles published, and that is due to the wonderful work of our editors. So why is it that we are having a lot of dental related publications post 2007? This is based on the top 5 publications, the topics of those top 5 publications. So these are the 5 publications which are toply cited out of India. These paper title hints to the area of active and rapidly disseminating research, and during 55 to 2007, most of the research was on cancers, precancerous, etiological, and risk factors for cancers. That is where most of our research came. The top research came in the last 5 decades or so. However, post 2008, things started to change a little bit. And that's when we have started to diversify, and now some good papers are coming. I'm not saying at all that good papers are not there. Some of them are really exceptional papers which come out, really worth reading, worth remembering papers that come out from within our country. But the numbers are much less than the desired numbers which should have been. So what are the reasons? What are the possible reasons that we run away from research? And I have deliberately used the word run away. There are a few things, which I feel are important for us to know. Some of you would relate to some, others to others, probably. All of us, and when we say us, I mean us, the teachers, have this key article syndrome. You do a good study, you spend nights and nights and nights, framing a good question or a good research question for yourself, and you go to your teacher, and the teacher says, okay, bring me the key article. If the key article is said from the point of view of figuring out from where, what is the what manuscripts are responsible for framing the question that this student has come to me, it's okay. But this key article syndrome is essentially, what you are suggesting, tell me where it has been done earlier. I mean, if it has been done earlier, why are you wanting the student to spend 3 years on it? Why are you so insistent on a key article? Why are you so insistent on a base article? If there is a base article, if there is a key article, and if it happens to be the only article, and if we really want to look at that article from the point of view of whether it has been done before and whether it is doable, then it is not worth it. Instead, we should, and the student also should be able to justify the research question that he has framed based on 10 articles. That this is a gap that I found in one of the studies I was going through, which has been addressed in these many ways, but still this gap stays. And this is the gap that I want to address. My area is the unaddressed area. And my area, I mean to say my geographical So, role of NSAIDs in the management of post-operative analgesia, as a post-operative analgesia, post-periodontal surgery. Ibuprofen, for example. It has been done over and over and again. But, sir, this has not been done in my city. It has not been tried on Chandigarh population. It has not been tried on Visakhapatnam population. It has not been tried on Kochi population. Why? What is the logic of this being tried on a local population? Do you foresee any reason that the results would be different from what the results are on a Kochi population if you do that on a Chandigarh population? So if you look into the research that a lot of students are doing, you will find so many of these, which are essentially addressing the same question but in a different population, and then the different population is a convenient sampling, is a population within their premises of the college, and that's what it is. Without a very scientific reasoning of why that population, what is in that population that probably would make them not react the same way as the population 200 kilometers away from you. Compare A to B and anything up to C. So we have a bone graft A and we have a bone graft B. And we have a bone graft C. Sir, bone graft A has been compared to B, B has been compared to C, but A has not been compared to C. Is there a viable reason why A should be compared to C? Just because A and X has not been compared with each other, let us compare both and frame a question. We get so many students coming to us with those kind of questions. You need to ask yourself what this comparison would tell us. Whether the bone graft A, which has been proven to be better than B, and B has been proven to be better than C, now comparing A to C, what is the result that we would expect? And why is it that you want to do it again? This is one major issue, piecemeal research versus sequential research. And this is a very country-specific issue, I would say. And this has to do with your teacher, with us. How does the research in the department goes? We have 9 postgraduate students, and all these 9 postgraduate students are addressing 9 different questions. And question 1 to question 8 has no relevance. Question 1 to question 3 has no relevance. And once these 9 students pass out, another batch of 9 comes in and they address 9 different questions. So essentially meaning within my department, I am not able to build up a area of concern, a area of priority for my research. If you look all across our country, if we have to look at identifying individuals globally who are good in immunity, in periodontal immunity, you can immediately say Professor Tom Van Dyke, Professor El Khattachi, Professor Hatija. You can immediately say that because they have spent their lives into it. But can you name one Indian researcher who can get up and say, I have spent 20 years in periodiabetes and periodiabetes is my forte. Here are my 80 publications on periodiabetes. No. And that is why when you enter a department, you really do not have a direction where you will go, because that department itself does not have a direction. And then you are asked to hunt for the topic, and when you hunt for the topic, you are asked for a PR. And that's why we are not able to do what we want to do. Yeah, I want to do a lot of things, but there's lack of infrastructure. My college doesn't have the basic facilities you're asking me to do a immunohistochemistry. No perio department in the world, and we have been fortunate to be working at Boston University, working at Harvard, Alpes now at Forsyth. No perio department in the world is fully equipped wherein that department can say, bring me a work and I will do it. You have to rely on others. You have to collaborate. The only thing you need in your department is a facility to store your samples. If you are able to store your samples, from getting them spoiled, properly store them, there is no research that you cannot do. You just have to hunt for a suitable place to do that. My samples go as far as Visakhapatnam for evaluation. Because we store them, we transport them. I don't have those facilities. We are working with COVID now. I do not have pseudovirion platform at my end. Absolutely not. That is available only in Visakhapatnam. So I have to send my samples there, but I have stored them. The only thing I have within my department and other departments around, those who are doing work, is that we can store the samples, and once the things start, of course, slowly and gradually you build up on the infrastructure also. So that is not an excuse at all. That leads to I, me, myself syndrome. I do not want to collaborate. I do not want to step out of my department and collaborate with somebody for which would mean me going to that facility 2 times a week for the next 2 years of my life. I don't want to do it. Please give me a simple topic. I don't care. Then your 3 years are gone. Which topic you want? 90%. If I ask you the question now, 90% of you would say, give me a simple topic. Why? Because we are surgeons. That is why we have joined Peru. My dear friends, you would start working on or if you would get a clinical research topic or a dissertation topic, you would start working on that within the 6 months of you joining your postgrad. And it would implant. Let us take implant. Implant is a good topic. I will do implant for my dissertation. Why? That way I'll be able to learn implant. If your idea of taking up a topic, a clinical topic, is to learn that procedure, please. So the first implant that you would be putting in your life would be your first patient of the study that you are going to do, wherein you would want to see the loss of the crestal bone loss compared to 2 implants. I'm talking very basic. So my dear friends, the bone loss that you will see in the first implant that you have placed is not because of the design of the implant. That is because of the lack of skill in your hand. If you have to do a clinical study, make sure that you achieve a level of perfection in doing a clinical procedure that you are wanting to test. And only then take up a clinical study. Just because you want to do a clinical study to learn the procedure otherwise. Who stops you from placing 50 implants? Nobody. But do not mix research and study together, ever. Lack of funds. Where are the funds? Let me tell you. We get a lot of funds from the funding. ICMR has one perennial problem. They say, we have money for oral health. Where are the projects? And the reason for that is, writing a grant is not an overnight job. You need to learn to write grants. Al would tell you much more than I can. I mean, he's an expert in writing grants. But it has taken him ages to write a proper grant, an application for the grant. The funds are not a problem. The problem is for us to sit down and formulate a worthwhile grant application, because that requires us. You do it, I can tell you from my experience, ICMR will certainly provide you. They are short of proposal. We have got, since we work closely with ICMR, they have asked us so many times, please organize a workshop for the young researchers. We will tell them how to write grants. We will tell them, we will handhold them. We will give them a seed money also for them to start the research. So lack of funds is an excuse and would stay an excuse, not a reality. And lack of networking. I wrote that again in just during my presentation here. Where do you do your networking? The networkings are usually done when all of us meet. The present times are not allowing us to, but when we meet and when we talk to each other, what the student in Nagpur is doing, what the student in Chandigarh is doing, what the student in Delhi is doing. But for us, the platforms of conferences are actually a gourmet feast. We don't go there, for our scientific appetite. So students, so these are some of the things that I thought, are excuses for us to not spend 3 years of our life into doing something which would be worthwhile. The document that you write, the dissertation that comes out after 3 years, should be the one that should give you pride 20 years later also. If you are doing a work on which you will be really not happy what you did during your MDS, it's not really worth it. And it is not impossible. I will share, we collected the data from some of our colleagues, and this is the work which is being done in India. This has come from Rajas, biofabrication of titanium herbal nanoconjugates, their characterization, evaluation of synergistic antimicrobial activity, effect of beta glucan biopolymers on the surface addition of osteoblast on titanium surfaces, association between NAT2 gene polymorphism coming out of Bangalore again, and chronic periodontitis, C-telopeptide of type 1 collagen, resolving D1 and TNF alpha. These are all being done as of now, as we speak. So it is not that the research is not being done. It's just that it is being so concentrated at so few places that it has not percolated. My idea of telling you all this is that this is possible. If they can do it, nobody stops you from doing that. Likewise, we have from Bangalore, Dr. Biju Thomas, a very senior person with us. Biological properties of human periodontal stem cells, formation from PDL-derived stem cells and comparative evaluation of inflammatory markers. Then we have something coming from Guwahati, from Dr. Spurga Jyotidas, Dr. Varsha Rathore from Bharati Vidyapeeth. A lot of work is being done. Huge amount of work is being done. Good work is being done. So we have this coming from Kozhikode. Then we have, there's no point in reading all this, from Kotiwal, from Kathak, Subhash Chandraraj, good friend, he's doing amazing work with his postgraduate students. We have this from Bhimavaram, Rajiv Gandhi, Bangalore. This is some of the work that we do. Now that I have the privilege of presenting, so let me so some of the work that we are doing currently is the analysis of M1, M2. Actually, this has been done already. Effect of periodontal intervention on oxidative stress in CKD patients going on. ICMR funded 3-dimensional finite element analysis of stress distribution in immediately placed, immediately loaded. Design and preclinical validation of a customized 3D printed dental implant. Development, characterization, and in vitro validation of composite anti-plaque agents based on selected phytochemicals. So these are some of the work that we do. Some have been completed, some in pipeline, some ongoing. So dear students, I would want to end and not come any more in between you and Al. But I would want to leave with this, that the best way to predict your future is to create it, and nobody else is going to create it for you. So create it yourself. Spend these 3 years in a way that you would be proud of. Thank you very much.
Thank you, Dr. Jain. It was really a wonderful and a riveting presentation. And I totally agree that interest in the fundamental research has been decreasing over a period of time because the focus has shifted towards the clinical, research. And that has perhaps been one of the reasons that why we see so little fundamental research, because it is always that what are the clinical implications. So we are more bothered about the clinical implications rather than, having something of a pure research sort of thing. Dr. Jain, if you allow, I may ask you a small question.
Yes, please, sir.
Sir, you have talked so wonderfully well about the avenues, and you have been wearing many hats. You have been at the topmost position in our society also, and you have been a top-ranked academician also. Sir, what do you think is the role of professional societies in making the student interest more in research, the MD students, the role of the professional societies as such?
Wonderful question, I must say, Dr. Grover. I think the professional societies and the basic owner should be on the professional society. Because this is the society, this is the platform where all the minds in that speciality congregate together. The society should actually create platforms for the young minds, for them to interact. We really need to get out of this psyche of coming to the conference and looking for food and more food and more food and more. We should at some point in time adopt to the culture. You go to an IDR meeting, there cannot be a bigger meeting than IDR. Where is the food served in IDR? You come, you learn, you present, go out in the cafe, have your lunch and come back. So the society really needs to take that onus on them in terms of creating enough opportunities for the students to interact, give them platform to share, let the societies, and we do that. I mean, fortunately, ISP does that. We started colloquium on a topic specific, and we are still continuing with that, wherein we go, all over the country at 3-4 places talking on a single topic. But that's what society should do. Society may also look in terms of hand holding some. I mean, excellent, Selva, you would of course write that. So Selva has taken, something that I was about to say in terms of having a multi-center trial. We have tried that at the society, in the society many times, and I think that is what the society should do. But again, society or anybody else would be an helping hand. Till the time I, as a student, don't tell myself that I have to spend my 3 years in a worthwhile manner, nothing will help.
Very true, sir. Very true. And I think within the society, we should find more means, to attract our young generation towards the research, as you've rightly said. And now, sir, I think it is time to call Dr. Alp. I would begin with the short introduction of Dr. Alp. Dr. Alp Kantarci holds a DDS and a PhD degree, and sir is a certified specialist of periodontology and a diplomate of the American Board of Periodontology. He's a senior member of the staff at the Forsyth Institute in Cambridge, USA. He serves as a faculty member at Harvard University School of Dental Medicine and as an adjunct professor at Boston University's Henry Goldman School of Dental Medicine. He has started his career as a dentist after graduating from Istanbul University in 1991 and moved to USA as a postdoctoral fellow. Upon completing his postdoctoral studies in 2002, he has started clinical periodontology specialization training at Boston University. After graduating, he was appointed as an assistant professor in 2004 at the Goldman School of Dental Medicine and was promoted to the associate professorship in 2009. In 2010, Sir joined the Forsyth Institute and Harvard University, maintaining his faculty position at Boston University. He's a practicing periodontist and implantologist. Dr. Kantarci is the clinical director of the Forsyth Institute's faculty practice, and during his academic career, he has been actively involved in training, education, and patient care, and has mentored more than 50 PhD, doctorate, and master's theses. Also taught in several graduate and postgraduate clinical and didactic dentistry courses, serves in the editorial board and a reviewer of more than 20 dental and medical scientific journals. His research interests include molecular mechanisms and resolution pathways of oral inflammation in periodontitis, experimental models, and he holds several patents also. Having published more than 150 articles in peer-reviewed scientific journals, he has written many book chapters and presented more than 500 oral talks and posters in dental and medical congresses. He is also the executive director at the International Academy of Periodontology and assumed the role of the editor-in-chief of the Journal of IAP in 2021. We welcome you, sir, with a good morning once again.
Thank you, Dr. Grover. Thank you. This is a great honor for me to present to my Indian colleagues and my Indian students. And I mean, it's been a pleasure. I wish I was there, but I'm just enjoying my tea right now, as if I'm in India right now, rather than only enjoying the beautiful Indian cuisine that I've been always like lucky to experience myself with my travels to India. And it's certainly a great honor to be with you, and it's certainly a great honor to share at least the virtual stage with my dear brother Ashish. And so it's really a pleasure to be at this position. And this is actually a really interesting talk because it's not going to be only a scientific presentation, but following up what Ashish has presented is hard always, because he always is very methodical in presenting the details, like the work. I'm more of a dreamer than Ashish, so I'm glad that I'm following him because I don't have to set the stage for what it looks like. But during our presentation preparations, we also discussed a little bit about like what we should talk to our young colleagues in India. So that's the reason why I prepared something quite different compared to what I'm used to present. So it's going to be still a lot of touching on the work that we've been doing. But I hope my colleagues will get more questions than my answers at the end. That's the whole mission that I've been doing in my life, to stir up more discussion, more curiosity, rather than giving the answers for that. So without further ado, I will share my screen. And if I can. So can you see my screen?
Yes.
I think we're all becoming Zoom gurus at the end of the day to do this stuff. So this is, it's a great honor to be here. First of all, I mean, this is what Ashish and I looked like. So when and we were not professors by that time. So we were just simple junior postdocs, just fresh. And as you can tell from the hairs, Ashish were lucky than me. I mean, his hair, of course, grew very, very dark for a long time, and I was always very jealous. But I'm glad that he caught up. So we're equally gray right now. So one thing I liked about this seminar title is also not only the title, but the question about can they go in hand in hand. I highlighted this over here because this is our life story with Ashish. We've been always going hand in hand for the last 21 years that we met. And after these wonderful photos, I didn't dare to put any photographs that were actually representing us in between. So this is what we looked like, and this is what we like to remember each other in many ways. And I hope everybody on the call will appreciate that you can, one thing that I can promise everybody is that you will stay young when you're doing research, because one of the advantages of our job is that we always interact with the same age groups, regardless of how old we become. So at the end of the day, we always think that we're staying young and we're staying very productive, very active, just because we train the same age group over and over again. So it's certainly a great rejuvenating, longevity creating exercise of being an academician, being a researcher, and being a mentor to our young colleagues. So I also took the liberty of changing my lecture title a little bit. And what I would try to push is that not to only talk about the MDS and research. And yes, the answer is, can they go hand in hand? I can tell that yes, the answer is very simple to the question. But what are we really doing today? And how can this be going through the education and dental research? And what can we do today? Can it change the way that we actually look for future? So that's what the entire lecture is going to be about. I prepared 29 slides, including my title slides, so I'm not going to bombard you with a lot of slides. And one of the things that I discovered through this past year of Zooming is that you cannot cover as many slides that you want throughout these lectures. And so there's always going to be some leftovers. And I also want to stir up some discussion as we discussed. But let's move on. So this question is how I start my thinking. Why dental research? Why should we even care about dental research? So last time when Ashish and I were together in India, we did the first colloquium back in 2013, when we traveled across India in 3 different cities in 6 days, including the travel. And it was in the Zoom times. So I wouldn't do this for a lot of people in the world. I did it for Ashish because it was crazy. We were like lecturing in one city, and I'm not talking about neighboring cities, packing up our bags in the afternoon on the second day, doing another trip to another city from Delhi to Kolkata to Bangalore in 6 days, literally, and traveling across the entire country with our colleagues from rheumatology, endocrinology, diabetology, and cardiology. So it was very learning, very teaching. And every lecture, if I remember correctly, Ashish was attended by about like 1,000 plus attendees. It was amazing. It was a great platform to talk to interact to each other, and also learn from each other, and also understand the country from different perspectives. And obviously, being in a country like in India, it's still a fragment, it's still a fraction of what we could be exposed to each other. But there was a great meeting organized by ISP there, and I really enjoyed it every moment. And at the end, we were very tired, but we really liked the way that we actually doing it. But one thing that we were like really recurring theme throughout this travel was, and throughout my career, is that first of all, you need to present what you're doing as unique. I like this banquet idea that Ashish was comparing the conferences. It's exactly the same thing. It's a delicious, very savory banquet that you're actually going to present your presentations to not only to each other, but also to people who are actually outside our disciplines. So why is it really important? Because what we're dealing with, dentistry and periodontology at large, is unique. So there's no way this can be actually reproduced anywhere in the entire human body or any in the mammalian body. And the second bullet point, it really talks about it. Teeth are the only mineralized structures that traverse the epithelium exposed to an extremely contaminated external environment. We periodontists, or the students of periodontology, as I try to see myself as well, is the only place in the entire body that deal with a hard tissue contaminated, and then really dealing with a very specialized mucosal immune surfaces. The soft and the hard tissues include and are resilient attachments, and these structures, being the periodontal ligament, is unique. There's no other joint, there's no other structure in the entire body. So we should start with selling our idea in this environment, in this niche. There's no one else better than we do what we do. So it's very important. The fourth bullet point, which is this part, which is within the sophisticated organ system, the tooth serves not only as an medium for external stimulus, but also its surface is an environment that accumulates and colonizes by a diverse group of bacterial species. Therefore, the interaction between the oral and dental and periodontal tissues and these organisms is a lifelong process that begins immediately after the tooth eruption. So this is very important. When I first moved to Foresight, my office, and it's still the same office that I'm actually residing right now, was next to Professor Sokransky's office. So he was my neighbor. So Sig retired before I joined Foresight. That meant in his life that he was still coming to work 4 days a week. Okay, so this is very interesting, and he was very early bird. I mean, I come very early, and then Sig was coming early, and every morning when he was passing in front of my office, he was quizzing me every morning and sitting in my office chair here, which is still the same chair, and he was asking me about what I was supposed to do that day. And this is pretty tough, because it's Sikros Sokransky asking you guys every day what you're supposed to be doing that day, and you have to come up with a new answer every day. And one day he said, Alp, we're very good in what we're doing, and we wrote the literature for the entire microbiology research in the rest of the body by doing periodontal immunology, periodontal microbiology. It never went away from my ears since that day, because we're so good in what we're doing. We're so specialized in what we're doing. We basically, dentists, periodontists, periodontal researchers, set the stage for our medical folks elsewhere in the rest of the body. And this was, don't take my word for this, this came actually from one of the giants in our fields. And I'm humbled to have that type of a insight by great master like him. And until his day that he passed away, he continued to come to work. And I saw him Thursday, and then on Friday he passed away. So this is what this passion is we're talking about. So the research is not really what you're supposed to be doing on your pastime, on your after hours. This is a lifestyle, and you can do different forms of research. So these are the questions that I pose to myself and to everybody on the screen.
Alf sir, sorry to bother. There is a one window appearing in front of your screen, which is a little obstructing us.
Is it gone right now?
Now it is clear. Yeah.
Sorry. So I use two screens sometimes because of that. Actually, that appears. So that's reason if I don't really look at you, I'm looking at my separate screen. So the questions here that we need to pose. This is the boring stuff, but it's critical. Is how can we add more science and research to our practices? Okay, this is critical because, as Ashish alluded very nicely, we train ourselves being very good practitioners, surgeons, periodontists. We place best implants in the world, and we're very good in what we're doing. But we never ask the question about how can we add more science. And compared to times that we were training, back in 1980s and 1990s, the science is very accessible right now compared to what we used to. And one paper that we were trying to fetch across the globe was impossible to get by that time. It's really at the tip of your finger, then you actually can reach that article very easily. The most important question is not how, but really, should we add more science? How can you justify this? I mean, why do you need to add more research and science if you can make tons of money on basically placing implants, treating periodontal disease? Why should you do that? So that's an important question that I don't really want to answer, and I'm going to leave it to this. How much would this cost? It costs money, but it's not that bad as much as you think. It's just a cost of time to sit there and then write the grant to be able to get money. As Ashish said rightfully, there is money for research. There is money nationally, internationally, globally, if you sell your uniqueness, which is exactly what we're supposed to be doing, as I alluded in my first slide. The most important part is scary. Everybody's scared of doing research. And because we're not trained well as dentists in our curricula to be not afraid from research. So that's very important. Another critical question is that where does it start and where does it end? As I was giving an example from Siksokransky's career, it never ends. It's a part of your life. It should be part of your life from the way that you should be looking at from the day one. And I'm going to give you some examples in the next slides. The most critical point here is that from our perspective, from dentists, from periodontists, it should be translational. So we should answer a unique question that is only important for us. Because if you're trying to go after your like other colleagues and things like that, you're not going to be able to compete because there's all the other people who are specialized, who are interested in doing what they're doing. But nobody can know and do our work better than we do. That's very important. So there has to be some translation around, which brings up to the question of basically where does it start and where does it end? It starts the first day you start getting your dentistry training, your periodontics training, because that's the time that you should ask questions about why, how, where, and how can I translate this information there. There are obviously limitations, and these limitations are not supposed to be something that we actually should be shy of or should be blind of. It will cost time. You need to separate time for doing this. It should be dedicated time. Resources are critical, but Ashish said it rightfully so. I worked in some of the best institutions in the world in terms of research, BU, Harvard, Forsyth. I collaborate with a lot of people at Penn, Pittsburgh, Michigan, and lots of places across the United States. In Turkey, there are a lot of centers, actually, really, really good research scientists. No place in the world has everything. So that's very important. But you need to be good at something for people to talk to you. So you cannot just really be just good in like basically reading. You have to present something. It's like a marketplace. If you go to a marketplace in India, in Turkey, in Brazil, in Turkey, in the United States, everybody sells something. Nobody sells everything, but everybody sells something very good. So that's what you're supposed to be doing. What is like basically a school in India is going to be selling to another school, which is one of the questions that came up to Ashish after his lecture, that person in one center should be willing to collaborate with another place. We can do all sorts of things in the planet to try to standardize, to talk to each other. But if I don't know what my counterpart is going to be giving me on my plate, I wouldn't collaborate. So you have to be very good in what you're actually promoting to another place. And that's exactly what's going on here. If somebody at UCLA is very good in that model of using systems that I don't really know about, I will go and collaborate with that person. But in the meantime, I have also something to offer on the table. My institute here is next to the MIT, next to the legendary Broad Institute, where the human genome was basically sequenced back in 1999 together with Oxford. So they're in the walking distance, like, in 10 minutes from here. But for me to get out from here and talk to them or call them, I have to have something. So one of the colleagues that Ashish and I trained with when we were doing our postdocs at Harvard, for instance, Claire Klesch, is the head of the sequencing operation at Broad Institute right now. I did my postdoc with Clary. Ashish met Clary when he was doing a postdoc at Harvard together with me and Clary. Clary is a very good friend. I meet with him on a daily basis to have drinks, coffee, and so on and so forth. But for me to talk to Clary for a research position, for a research place, I have to ask a smart question. And in return, I have to offer something. This is a difference between being a good friend, being a good colleague versus a good collaborator. So that's very important. So that resources should be very important to share with. Finances, as we alluded, is not something that you should be dismissing. Of course, it costs money, but there is money if you sit down and write the grants. There are variations at the global, national, regional, and institutional variation levels. Obviously, we actually have to be very cognizant, very respectful about what each country, each region, each institution would be prioritizing that. The problems in India may be different compared to problems in the United States or from Malaysia, from Singapore. You have to be very focused on what you're, again, prioritizing in what you're doing. And of course, the dental education should be the priority because we're not trying to create researchers. We're trying to create, at the end of the day, periodontists, dentists, who are very cognizant, very much interested in doing research and be really good at what they're doing in terms of research. But that has to be part of the curriculum. And it's not only us. This was published by the Royal Society in the United States, in the United Kingdom, a few years ago. It really talks about knowledge networks and nations from a very bird's eye view about how we can actually globally and scientifically collaborate in the 21st century. So that's an important article that I would, or like basically book that I will refer you to find out. So this was a work that was published by Stashenko and his co-workers in Journal of Dental Research a few years ago. That was about like 15 years of research. So he created this funnel, and it's really interesting because, as you can see, it's an upside down funnel. So we like to see it from bottom up. In this perspective, Phil Stashenko, who was our past president at the Forsyth Institute, and he's a great scientist, a great researcher, put basic science studies at the very top, okay? The reason for that is just like another funnel, it really needs to pour more water, more liquid than the funnel can handle. And there is a reason for it. Basic science studies will be basically feeding the animal studies that we have to translate, start doing those type of work. It will funnel even narrower to human studies. There has to be some clinical evidence that we should be looking at this. And there's actually a Venn diagram in the center. There's going to be a clinical problem, clinician, and patient preference. Without this interaction, interface between the clinician, clinical problem, and patient preference, there's no way we actually can do research. And then there's actually outcomes that will go back to ask the same questions. This is presented as a funnel, but obviously it doesn't end at the outcomes. Outcomes create questions to go back to basic science studies and so on and so forth. On the left side of this slide, I showed a couple of bullet points. A few years ago, I attended a lecture by Carlo Tinti, one of the best, like the bone surgeons in the planet that I've actually met, from Italy. Tinti presented a very interesting square in Italy, where he's from. It's a tiny town, tiny village up in the mountains in Italy. The square is full of chicken. He was looking at these chicken and he was just saying, I mean, nobody would make sense out of what he was trying to say between chicken and bone. He looked at this and he said, chicken is chicken. All chicken are alike, very similar. I mean, obviously they have different characters, but you cannot tell that from just an outlook. And same way, bone is bone. Chicken is chicken, bone is bone, research is research. So there's no such thing as bad research. There's a difference between publishable research versus non-publishable research. So there's, of course, good research versus bad research in terms of publications and so on and so forth. But at the end of the day, research is out of curiosity. And that's very important in my fourth bullet point over here. If you don't have a curiosity about any of these things that I listed over here, basic science, animal studies, human studies, clinical research, clinical problem, and clinical observations and outcomes, you're not a researcher. But there is a room for every single person in our profession to be a researcher. So my research interest can be over here. Your research is coming over here. But at the end of the day, we are part of the large puzzle. We're part of the large equation that we complement each other. So there's no such thing as bad question. There's no such thing as wrong question. But if you stop questions, then you will never learn. So you should start with the simplest. In your mind, it may be a very shy question, but you should actually do that. There's a question, however, next to one fits all. That doesn't reside very well in this type of a thing. One size does not fit all. So every type of a research here will have its own methodology. Every type of a dish in Indian cuisine has an expertise to cook it right. And that will be done in a very different fashion in the southern India, where they add a lot of spices, versus in northern India, where there's not that much spices. I mean, in my taste, it's still very spicy. But if I go down to southern part, then it's a very different cuisine. But it doesn't fit very well because it's a different taste. However, there's a different methodology for doing this. One of the critical things is that you need to be open to change. Research, one of the things that my mentor and Ashish's mentor, Dr. Van Dyke, told me the first day I joined his lab, is that he said, okay, our meetings, Ashish will remember very well, and still is, we're very short. I mean, Tom is one of these most practical persons in the planet. If you're done, you get out of his office. If you want to spend time with Tom, it's really after hours. But during the daytime, it's very much by the book, 15 minutes. So my first experiment I was doing in Tom's lab, before actually Ashish joined our lab there. And I went to his office and he said, okay, what did you find? I said, okay, I believe, and he stopped me immediately. He said, there's no belief in research. Your beliefs can go back to your church, mosque, your basically temple, whatever you do. There's no room for a research and belief there. Research doesn't have any beliefs. You can never use I believe. Until this day, I never use the word I believe in any of my stuff, in my presentations, because who cares what I believe? You don't care. What I publish is more important for that. So therefore, you have to be open for change. There's no dogma in this work. Just because I say so, that doesn't make something real or correct or true or a law. We're humans at the end of the day. So it is hard. It is hard to change your dogma. We all have gray hairs. We don't want to change. But if you don't want to change, you're done because you cannot adapt. So it is inevitable to do that. I touched the curiosity. Without curiosity, you're dead. Basically, you're not going to be able to do any of this stuff. You have to start with questions. Fun is essential. I'm still having a lot of fun on lecturing, talking, doing a lot of work in my lab and across the globe in collaborations. That's very important. And I'm going to come back to this investment issue, but it's important because it's very rewarding. There's a lot of returns on this one. It's hard, but it is a lot of returns and rewarding. You have to define your outcomes. You have to be very clear about what your outcomes are look like. And so after the question, you have to define what you're going to expect. These are the anticipated results. These are the results, data that you're going to be doing this, but you need to know how to interpret that. Last 2 points as the most important points of the slide. First, we need to educate the educators, train the educators from the beginning. That's why it is very important to infect everybody at the first level of their careers with this research virus. And it will mutate with you, just like COVID-19. It will learn how to survive with you, but you need to nourish this research virus throughout your careers. And you should start early. So I'm going to come back to the slides several times. So I picked up one critical thing out of everything that was on this funnel. It's the evidence. Without evidence, again, who cares what you believe? Who cares what you've been publishing in your entire career that you're basically dogmatically attached to, married to? It doesn't matter. The evidence can come with lots of ways. So we are only part of this entire team. It can start from college, high school students. I trained a lot of high school students in my lab, in my career. It can be dental students. It should be dental students. It should be part of their curriculum there. It can be you, postgraduate students. It will continue after you graduate. That's the reason why Ashish and I have been together for the last 20 plus years. We've met in our careers where we were very fresh, very raw, and we were not ripe enough. We thought we knew everything. As soon as we saw each other, we realized that we didn't know anything. So that's very important to meet each other, talk to each other at the postgraduate students. My students across the globe, they collaborate, just like me, what I'm doing. Because I will retire, I'll pass the stage to everybody who's actually junior compared to me. They need to keep on doing it. Junior faculty is extremely important because if the junior faculty does not get trained, does not get nourished with research, they will become very dogmatic. They will shut down everybody else in the planet because they will have to protect their turf. Senior faculty, therefore, has to be very, very critical of training the junior faculty. Junior faculty and postdoctoral fellows are our future. And dentists are our partners. They're not foes against, they are friends. We need to learn from our dental meetings. So that's the reason why, as Dr. Grover humbly introduced me, I'm humbled by Dr. Grover's presentation to me. I'm still a dentist. I'm still a practitioner periodontist. I still see patients. Yesterday, I treated patients just like you guys. I'm the head of the clinic at Foresight Institute. You cannot be away from your base. You need to learn every day because patients are the best educators for us. Every case is going to be different in your careers. So I highlighted the evidence here. For evidence, you need to observe, you need to watch, you need to see, you need to learn. And then you need to gather your data, your evidence from other people. Then you need to build your case and you need to justify that. Let's see how we can actually do that. So the mechanism can be summer internships, long-term internships, research lab rotations. It can be short, it can be long. It can be programs, structured programs. It can be combined programs. It can be CE courses after you graduate from your specialty degrees. It can be postdoctoral trainings. It can be sabbaticals. So lifelong. I'm now qualified to go for some place to learn sabbaticals. I can do a sabbatical in another institute just because of a professor, just because published more than 150 times and so on and so forth, just because wrote so many chapters, doesn't mean that I know everything. I need to continue. And I do it in the settings like IADR meetings. The rewards are decision of the papers, acceptance of the papers, better understanding of scientific basis of anything that you're doing, critical thinking, competition, awards, promotions, collaborations, advertisements. So these are your awards. And one of them is not better than the other ones. This is a lifelong experience to go through this. So that's the setting. So now I'm going to present a case study. Let's see what we've done throughout our careers. So with this, I'm not going to present something that I'll be walking through a lot of the science, but I'm going to show you how this actually is happening in real life. So I'm a periodontist. I'm not an orthodontist. I'm a rat orthodontist. I don't see humans. I see rats. I see a lot of basically other things that are actually associated with this. I treat a lot of cases with my colleagues from orthodontics. I got interested in this business of accelerated orthodontic tooth movement when we were at BU back in 2007. Until this day, after 14 years, we continue publishing in this work and we're still going very well. But I look at this from a much more of a biology and from the mechanism perspective. I learned a lot. When 2007, this was starting, when my colleagues from ortho department and from the different sections were coming to me, they came to me because of one thing. What was actually really important for them was that they wanted to do a trap staining, osteoclast staining on the rat samples. They found me. And these are the stainings that Ashish and I developed in our lab when he was doing his postdoc in our lab. So, and this is really interesting story because we had no idea what we were doing, but we learned how to do it. We talked to the pathologist and we were really good in what we were doing in terms of this work. And when we published this work with Charlie Serhan, that was exactly what we were doing with the rabbit studies. So years later, these guys showed up from the ortho department to find out how we can actually do the trap staining the osteoclast. And that's how the journey really started. We were very good in one thing that we were doing. We had no idea what these guys were talking about, why they should be accelerating tooth movement and so on and so forth in the first place, but they approached us. So that was how the collaboration started. From this point on, for the last 14 years, I've been very much interested in understanding this mechanism. So I'm going to use this as a case study to talk about the journey, about what we've done so far, and bring it on to 2020 and 2021 with this journey. So this is a case study. The question was a mechanism of acceleration of the orthodontic tooth movement. So what we knew when that time we actually started was that on average, it takes about almost like 1.5 to 2 years to complete conventional orthodontic tooth movement, especially in the adults. For those who are collaborating with the orthodontist, know that this is very true. By just increasing the force, we cannot just increase the rate of the tooth movement. On the contrary, it actually shuts down the orthodontic tooth movement because it does cause rhinalization, retrosorption, bone loss, and all the pathological things. Number one, we cannot move it faster. Number two, we create something that is not reversible. Therefore, the basic paradigm or basic premise of the orthodontic tooth movement is that you need to get sufficient bone remodeling for you to be able to move the teeth. This work was published in a textbook back in 2000, which is something that I found very interesting because this is based on 5 different theories. So in perio world, we don't have theories of how the teeth are actually responding, how the periodontal disease is moving. And believe it or not, the youngest theory in the orthodontic field is between 1973 to 1974. So they still don't know what to do with the orthodontic tooth movement, but they have theories about how this works. So the question that we asked, if this being supported by 100 years of research in orthodontics, and they still cannot go beyond the theories with the newest one between 1974 and 1973 range, back in 2000 and 2010 range. What is really interesting about this work? So according to this theory is that this entire movement is split into 3 phases. The first one is initial strain, when you activate the wires. Then it stops. There's a lag phase. Nothing happens in this phase. And then there's a progressive tooth movement. It goes in zigzag motions for this. So we asked the question, number 1, is this correct? Number 2, if this is correct, can we learn from this? Why everybody is interested in this initial strain and progressive tooth movement, but nobody really cares about this range over here? Can we learn stuff from the phase that nobody is really paying attention? Because clinicians, as we all are really interested about this outcome. We move teeth, but yet by just increasing the rate, by increasing the pretty much like the forces, we cannot move the teeth faster. It just stops it. So something happening before this evidence really is happening there. So that's actually over here. That's exactly what we've done. So this is the clinical evidence. What we wanted was to speed up the tooth movements without causing ankylosis, without causing root resorption, without tooth morbidity. Okay, this is a case that we treated at the very early part of my career. So we wanted to reach from this crowded case to this form faster, predictably, and evidence-based. How can we do this? So this is what we do really good. Surgeries. We know the bone anatomy. We know the bone physiology. We know how the reactions can actually happen. A periodontist is a very good oral surgeon by respecting the soft tissues. We may not be as fast or as good in looking at the complete impacted wisdom teeth and so on and so forth, or especially with the plastic surgeons or facial surgeons and so on and so forth, but we're very good in understanding the bone biology around the teeth. So this is one of the cases. This is a very severe case, as you've seen in the first ones. The corticotomy marks have been created. I'm not going to go into the technique. That's not the point of today. And we do this in maxilla, on the buccal, on the palate. We do exactly the same thing in the lingual and in the buccal sides of the mandible. So it's a pretty big surgery, very invasive surgery. This is what it looks like after 12 weeks. No evidence of anything that is actually irreversible in this case. I don't show the first, second, sixth, and all the in-between times, but there's absolutely nothing going on that you cannot even tell that this case actually went through a surgery, such an invasive surgery if you do it right. The braces are here, the wires are here, everything is activated. And in 12 weeks, we were able to go from here to here. This is like 3 months. Okay, this is what happens in the clinic. You can replace this by implants. You can replace this by periodontal regeneration. You can replace this by any other clinical case. The question is not like basic, okay, this is great. We've done it. We make our money earlier. We serve our patients faster. This is our job. But the question here that we should be asking is how? How does this really happen? We learned from the beginning that this cannot be happening because we just cannot move the teeth faster by activating the wires faster. But how does this really happen? That's where the research really starts. Without the how, without the question of asking why, how, you cannot really incorporate the research and you cannot become a better dentist or better periodontist or better orthodontist, better multidisciplinary scientist. So the question of how brings up the question of possible mechanisms, which is your hypothesis building. Without asking a question of how, you cannot build your hypothesis because you cannot come up with the questions of possible mechanisms that actually deal with this. So at the very beginning, we asked the question, okay, there are 3 possible mechanisms this can actually be happening. One of them is that we speed up the tissue turnover. There's a higher tissue turnover, as I've shown you with that lag phase. We most probably had that tissue turnover earlier and predictable. Another thing that we actually asked the question is that, can this be a very precise anatomic area? Because if you want to move a canine or upright a molar, create a space for implant by just opening up a space between the first molar and then the first premolar to place an implant in the second premolar area, or resolve the crowding while we're actually changing this anatomies. We want this to be very specific in one area. We don't want this to dissipate to the other teeth. We don't want this to be going into the other directions that we don't want to deal with root resorption. So it has to be a very precise anatomic area. That's another how question. And what we also want from the perio perspective, that's our contribution really will come to, is we need to make sure that we regenerate the bone that we're losing by moving the teeth faster or by doing these corticotomy marks. Okay? So this is all coming from the clinical evidence. So far, I haven't talked to you anything about the basic research or animal research or any translational research. But now that the fun starts, because we did the evidence, we were very successful in the clinic case, we did our treatment, let's go into the models. This is the model that we generated at the very beginning. This was in 2007. First, we need an animal model because obviously you cannot do this in cell culture models. So you need to move teeth. But you cannot do histology in humans with this invasively. So that leaves us with the model of developing an animal model. This is a rat jaw, rat maxilla. Obviously, we're not grown-up rats. So we cannot just be imitating what the rats are doing. So there are limitations. One of the major limitations is as you can see from the slide, they don't have premolars or canines in the rats. But that creates an opportunity for us. Because now, without trying to extract teeth, we can move teeth into the space that's empty. So the ultimate goal will be to move the first molar towards this incisor area in this edentulous site of a rat space. So that's an advantage of a rat model. So what we did was we actually created the burr marks around the rat first molar. So the first one was a proof of concept. And the idea is ultimately to move here, but we have no idea about the rats. So what we did was we created these burr marks. As I said, rats are not mini humans, or humans are not grown-up rats. So the first molar, instead of our molars, does not have like 3 roots, but it has 5 roots. So the first, second, third, fourth, 5, regardless of you basically count them. This is the mesial, this is the distal, this is the second molar, this is the edentulous space. Ultimately, we're going to move this tooth here. This is what happens after the 3rd week of putting burr marks. And on the right side of the slide, you see that there's absolutely a huge, massive bone loss by just creating burr marks here. We didn't get it in between the roots. We just created a burr mark on the buccal and the palatal aspects of the roots. So at 3 weeks, you cannot trace much bone in the interradicular space here. Very little bone is left. At this point, we also didn't know one more thing about the rats, about the timing. We know about how things heal in humans, but we don't know anything about the rats. So that's what we did. This was the first proof of concept study. So before we even published this work in a high quality journal, we need to do some homework to do. We need to develop the model. So this is what it looks like. 3rd week, the light green is where the surgical sites of the interradicular space. It's all non-bone. Bone is, this is the bone part, this is the non-bone site. The non-bone site, which we will conveniently call it as PDL area, will expand, whereas the bone will be going down, as I've shown you in the previous slides. Compared to the other side of the rat, same animal, where we didn't do burr marks, where the bone to non-bone ratio is the other way around. So 75% of the space is covered with bone, as opposed to 25 to 30% of the space is covered with the PDL or connective tissue space. It's the other way around in the surgical site. By 7 weeks, everything goes back to normal. 11 weeks, you cannot tell the site that received surgery versus the site that did not receive the surgery. So we're good. Number one, we answered that this is a reversible process. Number two, rat model will work for us. And third, we identify the time that we have in our hands to move the teeth. Just for your notes, and one thing that we discovered throughout this process, the time that you can move the teeth for the accelerated orthodontic tooth movement in rats is very similar to humans because it's exactly the same first 2 to 3 weeks that you need to accelerate the tooth movement. So that's another thing that we learned. So we looked at the osteoclast markers. These are the osteoclast or pre-osteoclast cells around the bone. And then by the bone that's actually covered with the PDL, there's nothing going on. Another thing that we asked at the very beginning, as you may recall, is that this is the red line where the surgical site of the control area that we did the burr marks versus the blue that did not receive surgery. So osteoclast counts went up 4-fold almost here. And then they went down, they dissipated completely by 7 and 11 weeks, completely flattened. And here, this is the question to the second hypothesis that we asked here. Remember, we wanted this to be very localized, very regional. And it is. The brown and the green are from the third molar site, where we did not put the burr marks. So nothing dissipates beyond the area that we wanted to do. So we answered the second question. And the third question that we answered in this paper was, or we posed this question, can we regenerate the bone? So this is all osteoclast numbers. So we injected the animals with the calcium red, calcium green, tetracycline orange, alizarin red at different time points. This is just like a tree trunk. And the control site, surgical site, by 4th week, there's much more bone formation, similar to much more bone resorption in the 4th week, as opposed to 7th week. So the amount of the bone that we lost was also built by the osteoblastic activity. So the third question that we posed at the very beginning was the hypothesis saying that, okay, we need to regenerate what we lost. And we did. So the entire bone formation actually happened. So the rest of the paper, you can actually see it in this work. So I spend more time on this one. I'm going to spend much less time for the rest of it, but just to give you a concept. So the first paper, take-home message out of this entire work, is the most important paper that you publish. So you need to put 90% of your time designing the first paper, because everything else will be building on that. It may not be published in a huge journal, doesn't matter, but it has to be scientifically peer-reviewed and give you confidence, not to yourself, but also among your peers, that this is a good stuff. And what you're posing here should convince you before anybody else gets convinced. So you need to be very critical about your own work at every stage. Every stain here, every cell type that you're actually mentioning here should be going through utmost scrutiny. You cannot believe in what you see. You need to believe in what you count, what you measure. This model that we did over here is unique because until that day, nobody really measured this. When we saw these images with Dr. Ferguson, who was the head of orthodontics by that time, okay, he said, Alp, how are you going to measure this stuff? So we talked about a lot of things. And what we did was, one thing that you observe here is the thickness of these lines, nothing else. My father was a professor of forestry. So in my very young ages, I counted the age of the trunks of a tree, okay? So the way that you will understand the age of a trunk of a tree will be counting the circles. And the years that the trees will go through droughts, you will have very thin growth. So the lines will go very thin. The years that you will have a lot of precipitation, a lot of rain, a lot of snow, the tree trunks, the circles get wider. That's exactly what happened here. So this is what the tooth looks like, and this is where the bone looks like. You basically measure the green, first stain, thickness, then the orange, the second injection after 1 week, and third, the red. So by the time rats ingest this in their drinks, you will be building this thickness. So when the rats are growing more bone, they will have larger growth, just like a tree, because there's more precipitation there. It's exactly the same thing. So we came up with this model, and we developed this model of measurements. We measure the thickness throughout the entire trunk of a root. We did this with every single root that you've seen. So it's a tedious process. It requires a lot of time in front of your computers, your screens, and things like that, but it's very simple. We developed this, we measured this, and it showed exactly what we wanted to describe. The picture here is great, but you need to quantify that. You cannot just convince me out of one picture, because I will be asking you, okay, what happened in the next one? This one is real. This one is something that I can actually trust, because it shows variation, standard deviation, standard error, and bars that are actually represented in these pictures. So that's where the science really comes to. So this is the second study. Now we got the model, we wanted to move the teeth. So I'm going to spend basically one slide on this one. The rest of them is published. All work is going on. So this is the control site. This is basically the tooth, the first molar that we want to move. Remember, we developed the model around this first tooth, but we did not move in the first study. Now it's time to move this. Now we killed about like 114 rats to be able to do this with lots of groups and so on and so forth at different time points. We learned the timing. I'm not going to get into detail. And here, again, we wanted to develop a model. So this is rat cephalometry, in a way, if you will call it. I told you that I'm a rat orthodontist. So we treated these animals and we developed our models. So this cephalometry is taking an NFAS, like basically occlusal x-rays that we think would be useful. Of course, it wasn't designed for rats, it was designed for humans, but we just took the liberty of putting our rat jaws there. We took the x-rays. And then we looked at the control site versus the surgery site of the same animal. You can see the distance opening. Nothing is happening between the second and the third molar, which again shows that this is regional. But we developed a rat orthodontic appliance model. We moved the first tooth, first molar, mesially to the edentulous space between the first molar and then the incisors. And it did work. Then we quantified the distance. That's it. Very simple. Everybody can do it. But you just have to ask the question based on our experience, because we were looking at this. And when we looked at the quantification of that distance, we found that the classical orthodontic tooth movement, which is in blue, shows exactly what hypothesis, what these laws, what these theories have shown. There is an initial strain, which is happening around like the second week. There's a lag phase that's actually happening, and then there's a progressive tooth movement. Obviously, as I repeated myself several times, rats are not like humans, so orthodontic tooth movement is very much limited to the appliances that we can actually create. There's a limit that you can actually move the teeth, but we got what we needed. In this combination group with the corticotomy, we bypassed the first phase, okay, because we were moving the teeth in an area which didn't have that much of a resistance coming out from the tooth, from the bone. So that first jump start actually followed this, move the teeth faster and longer distance as we could measure from here. And then after the fourth week, it started imitating what the conventional orthodontic tooth movement looks like. It's exactly what happens. So that also shows, just like in humans, we have a window of opportunity in the first 3 to 4 weeks. Just like in humans, we cannot move them more. So you learn as you go, but you also publish as you go. Another thing that we did was that we took, this was completely crazy out of this, we looked at the distance and we divided that by the day. So we wanted to look at the rate. Again, nothing genius in this one. I'm not Elon Musk. I'm just a simple periodontist as a dentist. But I'm trained to observe and learn. That's exactly what happens here. The rate was even more impressive. Look at this. When you divide the rate, when you look at this from a rate rather than a distance, you can easily differentiate the combination group doing much better than the conventional tooth movement group. The third study was asking the biology of this. So how does this really happen? So we developed the model. We proved that in the clinical sense that we're reproducing what we see in humans. Now the understanding is that why are we killing all of these animals? Because you could have done the same thing in humans anyway, so far. More or less. You cannot do histology, but you can actually do a lot of radiological methodologies and things like that. The beauty about using an animal model, of course, you can do stuff that you cannot do in humans. And that's where the real power comes from. So what we did was we looked at the life map of an osteoclast. We looked at the life of an osteoblast, and we looked at how the osteoclast and osteoblast collaborated with each other, talked to each other. So the life of an osteoclast can be traced all the way to the progenitors coming from the hematopoietic osteoclast precursors. And then there are several cytokines, several ligands, several basically cytokines that actually evolve in this, and several transcription factors. You can map the entire hematopoietic osteoclast progenitor, becoming osteoclast precursors, mononuclear osteoclast, quiescent osteoclast, and become an osteoclast by looking at these markers, just like us. You can identify person A from person B, person A's childhood from person A's adulthood and aging by looking at markers. Why cannot we use the same methodology here by learning the basic science behind this? So the question is exactly the same thing, much simpler for the osteoblast. There are mesenchymal osteoblast progenitors committed by the bone morphogenetic proteins to osteoblast precursors, can be mapped by RUNX2 as a precursor of a transcription factor. You can take a look at parathyroid and so on and so forth, converting this osteoblast precursors to active osteoblast by looking at alkaline phosphatase, collagen, osteocalcin, and so on and so forth. Life of an osteoblast. Life of an osteoblast, very similar. And the way these guys are going to talk to each other will be osteoclast and osteoblast talking to each other by looking at Rankel and rank, basically binding to each other. One of them is a receptor, the other one is a ligand. That's it. Without the osteoprotegrin, without the Rankel or rank communication, osteoclasts are not going to call for help from osteoblast, or osteoblast will not stimulate osteoclastic activity. So this is the key. So that's exactly what we've done. We took these bone specimens from these rats and we ground them down. Again, we developed our own method of how to grind down the bone from the rat jaw. Rat jaw, or any bone, for those who have experience in this one, is very poor in RNA. Doesn't have that much RNA. So lots of methods actually used, lots of different technologies, basically combined, pulled lots of RNAs from 10 different rats to be able to do that. So we didn't have that luxury because we killed enough rats for all of these groups anyway, for different time points. We needed every single rat as a group, just like in humans. Every rat counts. So what we did was, we looked into the literature and looked at who else was struggling to get enough RNA from different tissues. We found that the best methodologies, the most accurate methodologies, were developed with the lipid biology. Adipose tissue is also very poor with RNA. So we modified the RNA extraction method that was designed for fat tissue, for adipose tissue. And we adapted this over here. And that's exactly what we've done. That's exactly what we published back in this paper. So this again shows that Rankel goes up in both tooth movement and connective tissue combination group. And then there's not that much of a difference. However, as soon as Rankel goes, which is the osteoclast precursor, osteoprotegrin goes up, which is the osteoblast precursor. This doesn't happen in conventional tooth movement. As soon as this goes up, which is the bone resorptive factor, bone opposition factor, bone building factor goes down, as expected. So Osteoprotegrin being an osteoblast marker, mature osteoblast marker, going up with an osteoclast marker, which is RANKL, tells us we discovered something. This discovery was we're not speeding up the orthodontic tooth movements, which is here, molecular-wise. We're defining a complete new healing pattern, which means in this experiment where we combine corticotomy plus tooth movement, we also have a corticotomy group, which I'm not showing over here, but that didn't really show that much of a change over here. We're not adding one, which is tooth movement, and another one, which is corticotomy to get two. We're creating 5, which is not 1 + 1 = 2. This part, the green line here, I can talk about this, but we don't have that much time, and that's not the focus today, is a new discovery. Because what we've discovered here is a complete different healing pattern in the jaw bone by combining 2 different methodologies. One of them is our expertise, which is the surgical expertise. The other one is the biomechanics applied to the tooth. And at the end, the combination ratio goes down, which is also another discovery, because this is what you expect to be able to move teeth faster, to resorb more. But this shows that what you're doing here is that slowing the resorptive fashion. Therefore, what we're seeing here is basically a completely new healing that is reversible. And that's the beauty about this work. And this was published. So I'm going to spend a few slides about the future now. And we're going to wrap up with a couple of slides left. So can we get the same impact with something that is not invasive? The question is light. The answer is yes. So what we did was we used an extraoral device to move the teeth faster in humans. Again, our job is to answer human research questions. By putting the light from extraoral device, from photobiomodulation here, we did the rat studies, but I'm not going to spend more time in the rat models here. We were able to speed the tooth movements by 2.3-fold. By putting an intraoral device, we did exactly the same thing. We moved the teeth faster in this humans by resolving crowding by 2.1 to 2.8-fold. Okay. So where do we stand on this research? This is a gene array map. Every animal here is a rat. We did the gene array. We wanted to find out what else is going on in terms of the gene that actually turned on and turned off in response to these models. So this is the gene array that we're actually publishing right now. So the future brings information technologies, artificial intelligence to dentistry. This, what we're doing right now, is the future. Nobody could have told us that this was going to be where we're going to be about 1 year ago. So now, me not traveling across the world to talk to you guys, of course it has perks, like being presenting down of this work here, but it also has downsides. I cannot see you in physical appearance there, but it basically transmits the knowledge faster. So you are equal to me in terms of getting all the information. PubMed revolutionized the entire work that we're doing. Online access journals revolutionize the way that we're doing things. So information technologies are out there. But what we're really not completely fond of yet or understanding yet is that how can we train this monster that we created? There's a lot of knowledge out there. I just did a literature search because my next week lecture to be Boston University's oral biology, oral immunology lecture that I'm directing is about viral immunology in the oral cavity. I lectured this right after the pandemic started, right last year. Now I'm going to repeat myself again. In 3 months last year, we learned about 1,500 papers were published in COVID-19. I'm not going to ask that question right now, but I'm just going to give the answer very quickly. Right now, we have more than 110,000 publications about COVID-19. Nobody can read this stuff, and nobody can process this data in 1 year. There's no way. So we need computers. And every field is exploding in dentistry, in medicine, in periodontology, that we cannot catch up with this reading. So it is scary. That's the scary part. If you don't know what you're looking for, it's completely chaos out there. So you have to be very good in understanding, basic understanding what you're learning from the get-go. And eventually, learning your focused research question based on a hypothesis, and eventually make a case out of that. So it's very important. And we need systems biology, we need artificial intelligence, we need machine learning. We need to integrate these molecular, clinical, epidemiological data into these monsters that we created, so we can actually make sense out of that. So the future is really systems biology and understanding that. And India obviously has a very big expertise on this one. You guys trained some of the smartest people in the information technologies in the world. And that's what we did with Ashish. I mean, the plane landed next to the airport was this Bangalore Institute of Technology. And on the way to going into the city where we're actually talking about science and things like that, it's massive. This is the Indian Silicon Valley. You guys can do a lot on this one. So be on your turf, learn what you can do, and then sell something. That's exactly what the whole point is. And that doesn't mean that you shouldn't be doing other things, of course, curiosity, but you already have tools in your toolbox to dominate and to really be the people to go, be the researchers to go in your field. And at the end, there's a new scientific understanding of human biology is being born in every field. So I'm going to spend 2 more slides to give you what we're doing today. This is a paper that one of my postdocs, and I'm not a big fan of reviews myself, but this is something that I agreed on because this is interesting, because this is blending all the oral and maxillofacial diseases under translational aspects and putting the basic of biological mechanisms. This was published in Frontiers in Immunology. Carla was my student by then. Now she became a postdoc of mine, and she's originally from Chile. And Ashish and I are the testimony of this. Our lab is still an international, like a Mecca of having so many people from different places in the world. And this is an interesting work because what we did here is that we use periodontal disease, we use periapical diseases, we use all sorts of diseases that may have osteoimmunological bone loss where the immunology can play a role. And this is one of the cartoons there. I will leave it to you with the publication because I know that you're recording this. The one thing that I wanted to highlight here, and this was published in 2019, these applications can be the development of immune-based therapies that can promote bone healing and regeneration. The identification of host-derived inflammatory collagenetic biomarkers are diagnostic tools. You can read the rest of the abstract here. You can take a look at this more. If you don't have access to this, I'll be happy to send the paper to Ashish and to Dr. Grover so they can share with you. So that's one thing that we're actually doing. We're trying to find commonalities as opposed to being silos in research. We need to talk to each other. As I've shown you in the case study of orthodontic acceleration, we need to put our expertise, but we need to also learn from orthodontic colleagues. Same model applies here. And final paper that I'm going to share with you is a paper that we just published with one of my students, who's actually also another great collaborator right now from Brazil. This is a work that Ashish and I started our careers. This is where we stand right now. This was just published in 2020 in Frontiers in Immunology. We have something to sell. It was not gone through the scrutiny by the dentists. It wasn't reviewed by friends. It was not reviewed by collaborators. It's these 2 papers I showed here. They're actually reviewed by people who are not going to like who we are, but will trust the science that we publish. This was published in a very fast way. In this work, again, I will be happy to send this paper if you don't have access to this. What we showed was that inflammation is one of the major hurdles of periodontal ligament stem cells that we have isolated from the human teeth. I extracted all of these teeth myself. So Emmanuel did all of this work himself in the lab. And then what we did was we created immunoinflammation potential. And then we treated them with the resolvins and maresins. And then we were able to restore their regenerative properties. So now they can become osteoblasts, they can become fibroblasts, and they can become cementoblasts in vitro, by just changing their inflammatory process. And that's the cartoon that we published. So, in closing, the dental professional in 2030, I'm not going to be looking forward to retire, but who knows? I may be done, but it's you guys. Should be able to move beyond the challenges to expand the integration of biomedical research to dental medicine, patient care, and social services. This is the triad for us. You need to serve, you need to care your patients, and you need to be really thinking as dental medicine specialists and periodontal medicine specialists as doctors, not only as technicians who can just do a really good job in extracting the tooth, who can do a really good job in placing an implant, who can do a good job in moving the teeth. These are all technical skills. There's nothing wrong with that. You can be perfect in those, but there's something beyond that. You need to be a medicine person. This is a slide that I used before, so I'm not going to go through this. Take-home message is this: investments in science and knowledge in yourself has great returns and rewards. And with that, I thank you for your kind hospitality, and I'm honored to present with my brother in India, Ashish, and it's certainly a great pleasure to work with my young colleagues in India and across the world. Thank you so much.
Thank you, Alp. Yes, Ashish, sir, please.
Yeah, I mean, what a presentation, I must say. Absolutely, I'm blown. I'm completely blown in terms of. I mean, I know what else is all about. But I think what our students need to really look at is when he was showing the papers and you had those names on those papers. So only one paper was that. The other 5 names were his students. And those students are just like him. So essentially, in their record, in their life, they have been exposed to the kind of work, which they would be proud of later in their life. The only thing is, each one of our students here also can do it. The only thing is, they need to probably scout for help around. We won't have any help within ourselves, but at least you need to figure out with whom you want to work. And Alp, I mean, excellent presentation, Alp. I mean, there is no comment that would justify what you have just presented. But if how it is that how is the post graduation studies built up in US? Essentially, how would a student spend his 2 years or 3 years of specialty residency in US in terms of time devoted to research and in terms of time devoted to clinics?
Thank you, Ashish. I mean, thank you very much for your kind words. And I think my job is to pose everybody with more questions than I should answer. And I promised that, and I hope I delivered that. So stir up a lot of the minds. Don't believe what you believe, and then just ask questions, keep on going on with that. So that's the whole point. And I do this, and if I stop asking questions in my career, I would never be enjoying myself with what I'm doing. And then one other thing that was actually very important for knowing is that these international collaborations or national collaborations are so valuable. Carla is now writing a grant with one of the postdocs of my lab from University of Bergen and from Norway. And so she can actually go there and then learn a new technique there. So I'm very much willing to send her there, and because that's going to be investment for me. So I'm going to invest her to be investing in our store. So that's very important. As for the education, when I was listening to your presentation, I think there are a lot of issues and there are a lot of hurdles everywhere in the world. So it's not like what you presented is not unique to India. So you shared me with the curriculum before, so I went through the curriculum. Very similar. I mean, so everybody follows the same curriculum. So that's why a dentist is a dentist. I mean, a bone is bone, research is research, dentistry is dentistry. So it has advantages because we can train dentists wherever we are. So because we have patients. So dental practice has become a very, or has always been, since the dawn of the civilizations. I was just looking at an early implant. Somebody in ancient Greece, basically ancient Egypt, can do the same thing. Just taking a lost tooth and implement this and so on and so forth. That's exactly what the whole point is. So that's going to happen. But what makes a difference for us is how to create the future dentist. And everybody's asking the same thing. Harvard, which after I joined there and I took over the directorship of the immunology and microbiology course there, went through an accreditation. During the accreditation, the same question is being asked. Because in the US, as you know very well, accreditation is the most important thing. And if you don't get accredited independently and very fiercely by the American Dental Association, you're not going to be able to accept students. And since students pay so much money, of course, that's your lifeline. So you need to really do a really good job. But what they discovered in this case study or self-study was that they were not really building the dentistry for future. They were building the dentistry for today or for past. So the same question is being asked. So I think there's no easy answer for it. But one thing that the push is to increase the work that what we're basically implementing. So every student, every master student, every doctor student, every dental student, even every pre-doc student, in the US, of course, there's a college and then you go to the dental school and so on and so forth. These schools have to present research. So if my high school students or my college student, pre-dent students, can show that he or she has spent some time, summer. We have a research summer program at Foresight, for instance. We train high school students here. We train college students in my lab. We train dental students in my lab. To not only to beef up their CVs, but also infect them with the research virus, as I was saying at the very beginning, as early as possible. Make them as critical thinkers. The return is this. Last year, I was lecturing and I gave a talk about the resolvins and epoxins. And we talked about our cutting edge research there. And this was Harvard students, dental school students. And I asked a question. I said, okay, according to, what is the healing mechanism of this? So the response was, and this was a lecture that I gave in March. I asked a question in April about an exam. So the student answered, saying that according to what you lectured in the class, this is the right answer. But according to the publication that came from Dr. Serhan's lab I think it was 2019, because I did it in person, 2019 April, the answer should be this. That's what I want. And I gave the student full marks, and actually gave him bonus, because that is the student that's going to pave way for us in future. That is our future. Not take my words, even if it was only 1 month ago that I presented that work, it was still up to date. Not take my words, go and look for the answers. Not everybody will do it, but those who will do it will be the leaders of our future in every field. So I think we should just make sure that what we're doing in terms of our lectures, in terms of our research, we just have to make sure that this is not scary to think. This is not scary to ask questions. Please ask questions. Please, without questions, you cannot answer the questions. I think it's a long answer, but I hope I gave you the answer that I.
No, absolutely. I think this is what we also want our students to kind of implicate within themselves. Dr. Grover, if you have.
First of all, Alp, it was an awesome presentation. We really, enjoyed every bit of it. I just want to ask you one thing, that our student community, our postgraduate community, like in US, they have say about 2 years or a little more than 2 years to do their research when they are in the university or colleges. And most of the times they are opting for, clinical research, and they have a small sample size because they have to make do their research within a limited period of time. Now, because of the small sample size, there's a low, statistical evaluation, and most of the papers, they fall flat, in international arena when they go, because of the small sample size as such in their studies. Sir, what would be your advice? What sort of topics they should, really look for, so that they can complete within a limited period of time and they are more acceptable at the international level?
Yeah, I mean, that's a great question, Dr. Grover, and thank you very much for your kind words. As I said, I'm very honored, and it's a humbling experience always to present such a distinct group, and that's perfect. And I congratulate ISP for its wonderful efforts, and truly enjoyed every meeting that I organized and I joined with the ISP. So congratulations. So that's a very important question. When you're doing clinical research, size matters. I mean, that's it. So without sample size, without a good power estimates, unless you're working in a very rare disease, which is not the case in oral cavity most of the times, there's no way the PERC will be published. So I think it's a wasted effort in lots of ways. And I need to be blunt about this, because unfortunately, that is actually the most important thing with this, because most of this work is wasted. I mean, people think that research, clinical research, is easier. And yes, it is easy for us because we've trained as clinicians. But the variation at the human level, and there's a reason why we're doing a lot of animal models, is that because variation is not that much. But that doesn't mean that every animal result is going to be translation to humans. Most of the times, the work that we've done with Ashish, with the rabbit models, whenever we were ready to move to the humans, they said, well, you haven't really published anything that's a relevant model in humans. So what we had to be, we were asked by FDA was that to do a pig study, or like a large animal model. So we had to go back and repeated some of the rabbit models and we did the mini pig models to be able to at least talk to something human-like. And then when we went from pigs to humans, again, surprise, surprise, most of the things that we thought was going to work did not work. Some of them worked. I mean, of course, it was safe and so on and so forth. That was great. So humans have shown a lot of variety. And so in a country like India, I mean, there's a lot of different nationalities, not nationalities, but there are different ethnic groups, different cultures. Obviously, you need to be very cognizant about the sample size. So that has to be representing. Even in the United States, compared to Turkey, for instance, the population is very diverse. Every time we do a clinical study, we have to represent African Americans, Asians, minorities, Hispanics, American Indians, and so on and so forth, different regions. So that's important. So what I would recommend before jumping into a clinical study is to do a power analysis and know your power and know how much you need to recruit, how many patients. And the second thing is that make sure that your inclusion and exclusion criteria are very, very good and very well designed. Not saying strict, because strict means that it's maybe actually also self-limiting, but you have to be very clear about the inclusion, exclusion criteria or demographics. In a way, the table 1, which is your demographic tables, should be done before you even do the study at the tentative phase. Of course, you were going to be having retention issues and things like that. Once you do that, once you do a statistics at the very beginning or design of this, it doesn't really matter what your research question is, but you have to be very good in terms of the power, sample size, inclusion, exclusion criteria. Once you do that, you're basically 50% done, because the rest of them is really the methodology that you need to ask about your research questions. That's for the clinical research. And without this, I don't think there's going to be any chance of any paper getting published in a clinical journal. From the translation perspective, from the animal studies, just repeat. I mean, basically, that's a wonderful way to follow the things, because you just have to reproduce what people have done in different parts of the world. And what I'm doing is not rocket science, as I was sharing with you. I'm not saying that it is easy, because you need to put a lot of things together. But I'm also saying that this is not a genius thing. At the end, I'm just a human being with average IQ. That's it. But I happen to be lucky to work with good people who show me the way to think, to question who I am, and still do. I mean, one of the things that Tom and I do a lot is that whenever I have an idea, I run it by him. And he is the most critical person. I gave you the example of Sikro-Kransky at the beginning. So be very critical about what you're doing. But beyond that, I don't think once you do the power analysis, once you do anything that's actually design, I typically spend more time designing the studies. And 75% of the time I spend designing anything, basic science, translational science, animal work, human studies. 25% is the execution. And that formula applies to any research that you're doing, even in the epidemiological research.
Absolutely wonderful, sir.
That's good numbers for us to dwell on. We have Dr. Anirban with us. He's our president-elect. So he's still around, and he has, I think, a couple of questions to ask you. Anirban, if you can unmute yourself. Yeah, we have Ashish also with us, our editor, who's wanting to ask. Anirban, if you can please go ahead.
Yeah. Alp, it was a wonderful talk. I really appreciate the amount of work you have done related to corticotomy and all those things. I just have one question. What about the osteoid doing any of this? Like you have spoken about osteoclast, osteoblast. Anything to do with osteoid? Have you worked upon that?
Sure. I mean, thank you so much. Thank you, Dr. Chatterjee. And as I said, I'm always having a lot of fun, as you can tell, by presenting to people who are interested in listening. So that's actually important. And this is our life cycle. But regarding the osteoid and the osteocyte, I think there was also a question about the osteocyte in one of the queries there in terms of the chat. I mean, osteocytes were seen as nuisance until 20 years ago. So nobody cared about these cells. They thought that these are pycnotic cells that were actually trapped, left over with no function. And now we're just scratching the surface about actual function about the osteocytes and how they become very active cells and very metabolically active cells to become active osteoblasts. And it's also important because some of the osteoid tissues, and especially the osteocytes, also very stimulating what the mesenchymal stem cells are doing. So they are actually they're guiding their stem cells. So osteoid tissue is unfortunately very difficult to obtain. It's not like extracellular space is actually more of a connective tissue area. However, osteoid tissue has all the growth factors that can stimulate the bone formation and also bone resorption to get a healthy tissue. So therefore, just like in osteocyte case, osteoid tissues are going to be very critical for our future. And that's exactly where we went to one step ahead and asked the question of, can we have this mesenchymal stem cells or progenitor stem cells or inducible progenitor stem cells, which is the stem cell population, especially in the dental pulp right now, which is a line that we're trying to finish up right now, which compare their function compared to the periodontal stem cells and the mesenchymal stem cells. And they have very interesting characteristics that are very common, but they also have uniqueness. So coming back to your question, I think the osteoid tissue, being an extracellular matrix, has a lot of similarities with the extracellular fibroblast tissue, so connective tissue type of things. But there's also a lot of uniqueness because fibroblasts can have the capacity to regenerate bone, but they don't have to. Number one. Number two, they do have a capacity to become pro-inflammatory cells, but they don't have to. Osteoid cells or osteocytes or osteoblasts, to that matter, they do have the capacity to become basically converting the epithelial cells different levels, but they don't. So the machinery is there. So the net outcome of this discussion is that osteoid structure, osteoblasts and osteocytes have all the machinery, but they are highly specialized in building bone. The real question that I'm actually supposed to ask at this point to myself is, why are they so specialized in the alveolar bone as opposed to long bones, as opposed to flat bones elsewhere? So what is actually really interesting about the alveolar bone? Because this structure is also very much stimulated by the biomechanical forces. And that's the reason why I'm actually always calling myself as an eternal rat orthodontist, because I don't really care about how much these guys move the teeth or not. But my question is that how can we learn from them about how the biomechanical forces are doing? Because they are inducing the biomechanical forces, but without that induction, this phenomenon of this orthodontic occlusal trauma versus traumatic occlusion never going anywhere, because we don't know enough about occlusal forces, because we never paid attention to the biomechanical forces that are exerted by the teeth. So that's exactly what we should be doing, and this is exactly what I'm very curious about to learn, because osteoid tissue in the oral cavity, in the alveolar bones, in their basically teeth that are actually surrounding them, and to that matter, alveolar bones surrounding implants, are so specialized compared to the long bones that orthopedics cannot really teach us enough about orthodontics or any of this entire spaces that we are actually doing that. So, but the short answer is I don't know. But the long answer is there's a lot of curiosity that we need to find out there.
Thank you, Alp, for a wonderful thing. And just second question is, as per you, corticotomy, I have done a lot of cases of corticotomy with dissertations and all. Piezo is a better, or a burr is a better to do a corticotomy? Using a burr?
So I've done both of these experiments.
Yeah.
So I use piezo a lot. My sinus lifts, for instance, I do a lot of them with the root extractions and so on and so forth. Piezo is a good device. It's really causing this. But in the rat studies, what we have seen is that the piezoelectricity induced corticotomy in the rat models, which is something that we published with Serge Dibar, is prolonged. So compared to the basically simple alveolar decortication that we're using with the surgical methods, the healing takes a bit longer. I don't know the answer for that yet. So most likely the model, but it does heal. Instead of going after 42 days, it heals in 56 days, 6 days. It takes about like another 2 weeks. But I think there's an explanation for it, because we use the piezoelectricity as a surgical tool. We don't really care about what it really does. There's a theory in orthodontic literature which actually talks about the piezoelectricity theory. This was actually established in 1969. This is a model for that. And this was created by Shelley Baumrind, and who I happened to meet him. He just passed away last year. But so they didn't look at this from a surgical perspective. They looked at this as saying that, okay, can piezoelectricity play a role in orthodontic tooth movements healing? Nobody followed this literature from that angle. And till this day, I don't think they actually have very big curiosity about this, because we don't have enough insight about how to test. We don't have enough good outcomes about what piezoelectricity does. So it was a theory that was buried in the textbooks, and nobody really cared about this too much. So I suspect that what we're seeing in piezoelectricity induced corticotomy accelerated tooth movements, and I push every word, stress every word there on purpose, because orthodontic tooth movements is a biomechanics. Surgical decortication creates a surgical tooth movements. Yes, we actually injure the bone, but piezoelectricity is not very harmless either by itself. I mean, it's not naive, it's not inert by itself. Most probably the electricity that we actually induce to the tissues creates a different model. At the end, it heals. So I'm not saying that one of them is better, one of them is worse. In periodontist's hands, it's perfect, because we know how to not to harm tissues. So, but the healing biologically may be different, and I don't know the full answer for that yet.
Thank you, Alp, for the answer, and it was a great interaction with you. Hope to interact with you in future.
Sure.
And let's go forward.
Sure.
Thank you, Dr. Grover, and thank you, Ashish.
Thank you very much
for a wonderful interaction.
Thank you. So
Yes.
if there are not that many questions, I will have to excuse myself, unfortunately, because I need to run for another meeting. But I don't know what Ashish, Dr. Grover, are there any last minute discussions that we actually have? I don't see too much questions.
Alp, as usual, you have probably, answered everything even when you were asking. So we all, have really gained a lot. As much as our students, as our faculty as well. So thank you very much once again for your time. I mean, no words would be enough to really thank you for what you have been doing with us at ISP and with you now at the head of affairs at IAP. Let us look forward in terms of collaborating also at the society level, and take the next step together. We really hope to see you soon in person as and when it is possible.
Sure.
And thank you so very much again, Al, and convey our regards and love to Aditya.
Thank you.
Thank you so much, Al. Thank you so much.
Thank you, Al.
Thank you.
Thank you.
Thank you, Dr. Grover. And
Thank you so much.
I look forward to seeing you both in person and my colleagues. And but good luck and thank you very much for organizing this. And it's always
Surely.
a pleasure